Good afternoon, everyone, and thank you for joining us today. My name is Julia Wyson, and I'm with the Academy of Life Underwriting, and will be your host for today. Before we begin, if you have housekeeping items, if you happen to have any questions during this presentation, feel free to type them into questions box located on your right-hand side, and we'll address them as time permits. Right below it, you will see the handout section where you'll find the PDF slides for this presentation. So you may skip on taking notes or feel free to continue taking them, as well as an overview of the continuing education program and the instructions on how to log in the CE credit for attending today's webinar. And with this out of the way, it is my pleasure to introduce our special speaker, Dr. Minas Joannidis, who will take us on a dangerous journey with his talk on rheumatoid arthritis. Dr. Minas is the Chief Medical Director at Optimum Reinsurance, and he'll be sharing his expert opinion on rheumatoid arthritis, diagnostic criteria, inflammatory markers, medications, and present several case studies. Fun fact is that both of his grandfathers and father were pulmonary specialists. The grandfather and the father were this thoracic surgeons, but you can correct me. I just learned that. That's pretty cool. So no surprise, he followed their steps and practiced pulmonary medicine in private practice in Florida before joining and switching career, joining the life insurance industry. He has worked as a medical director at MetLife in the golden years when it was mutual company at Tampa, Florida, and San Ramon, California. After MetLife, he served as Chief Medical Director and first VP, Head of Underwriting Operations at New York Life in the canyons of Madison Avenue, although he doesn't miss the 2-hour commute. Later joining Allstate and currently serving as the Chief Medical Director at Optimum Re. And with that, I ask you that you give your full attention to Dr. Joannidis. The floor is yours.
Hey, thank you very much. I hope everybody can see the screen. So we're going to talk today about rheumatoid arthritis as an inflammatory disease. So just a typical antitrust notice. We don't want to get the feds upset, so we won't be discussing ratings of any particular case or what business actions we would take, right? By the way, if you're ever at a meeting and somebody does start doing that, I've been told by lawyers to stand up, knock over a bottle of water, and leave the room. So everybody remembers when you left. So today we're going to take a dangerous journey. You probably wondered why I use that. Maybe some of you even thought we were going to talk about some kind of travel to foreign countries or something like that. But here's the plan today. I'll see if you're up for it, see if you're game. So I planned a mission, and the risk of this talk may be high, depending on how it goes. The outcome is unclear. The likelihood of success may be low, and there are no financial rewards. So I don't know if you're still willing to join me, but we're going to take a journey today and talk about rheumatoid arthritis. So if you're game, let's start. So it's not going to be the typical rheumatoid arthritis talk you've probably heard many times before, but I kind of created this for sophisticated underwriters, which you all are, who employ critical thinking. And you can't give a talk about anything today without mentioning words critical thinking, right? It's de rigueur, to use the French phrase. It's absolutely necessary to mention that. So we'll talk a little bit about critical thinking today. And we're going to talk about crafting customized decisions based on unique risk factors involved. So at your leisure, you can review the slides that I've put forward and kind of look at rheumatoid arthritis in hopefully a novel way as a representation of inflammatory diseases. And I attend a lot of talks just like you do, and sometimes a month later I can't remember one thing from those talks. So hopefully today you'll carry away just, even if it's just one idea, it may be a success for you or success for me. So let's get started. So rheumatoid arthritis is an autoimmune disease that attacks the synovium, the lining of the joints, causing inflammation and pain. And the typical targets are the small joints of the hands, knees, ankles in a bilateral fashion, feet. However, other organ systems can be affected by the disease as well, including cardiac, pulmonary, eyes, or other things. So what we're going to try to do today is understand the underlying concepts of rheumatoid arthritis and kind of pivot to a new perspective. So the way my brain works is when I approach something, I kind of deconstruct it, get down to the basic concepts, and then I kind of reconstruct it so that it's simplified and something I can understand. Because I can't tell you about something if I don't understand it. So I have to simplify things for myself. So today we're going to talk about what we're really rating as the inflammation or the inflammatory disease, not just arthritis. Okay? So we're going to analyze also the risks of treatment with biologics and the risks of reactivating dormant diseases that the applicant may have. So when we see in an APS, a diagnosis of rheumatoid arthritis, it gets us to a rating section in the manual, but we're going to be thinking about it slightly differently. You'll follow my talk today. So yeah, that we're still using the 2010 diagnostic criteria for rheumatoid arthritis from the American College of Rheumatology. And these are the criteria. Synovitis in at least one joint, the absence of an alternative diagnosis, and then it's scored with points, and there's actually 4 domains. So you can review this at your leisure, but the domains are number and size of the joints. You get more points for more small joints and fewer points for fewer joints or bigger joints. Serology testing, which we're going to talk about, that includes rheumatoid factor and anti-CCP. We'll talk about those, but you get more points if they're greater than 3 times the upper limit of normal, otherwise fewer points. Then if you'll notice, the elevated SED rate or CRP, which are inflammatory markers, you really only get 1 point for that. So that's kind of low on the totem pole. And then symptoms greater than 6 weeks. So we kind of rule out other short-lived situations, like if arthritis was due to a viral disease or something like that. So this is the point scoring system. So by the time we get a case, usually the diagnosis has been made, right? So the applicant has qualified for the diagnosis based on something along these lines. So in a differential diagnosis of rheumatoid arthritis, if sometimes the cases are a little hazy as to whether the diagnosis was made or not, now usually rheumatoid arthritis, in the picture I have at the right, I've circled in red the PIP joints and the MCP joints of the hand, as well as the wrist. Those are typical joints that are affected by rheumatoid arthritis, whereas in osteoarthritis, the DIP joints, or the distal interphalangeal joints, are more likely to be affected. Not that rheumatoid arthritis couldn't affect those joints, but usually it's the PIP and MCP joints, the wrist, etc. But other things to consider besides osteoarthritis are symmetric psoriatic arthritis, Lyme disease, and all of these other differentials have specific things that you would be looking for to rule in or rule out those diseases. Polymyalgia rheumatica, which would be more of a muscular presentation, but could affect joints, gout, and then the viral arthropathies that I mentioned, like parvovirus, hepatitis B or C associated arthritis, and then increasingly frequent cause of viral arthropathy is chikungunya, which is spreading around the world. And CDC just issued an advisory if you're planning any travel to Paraguay, but it's in the Caribbean, South America, Italy, India, a lot of other places. I included an entire slide on osteoarthritis, not that we're going to go into this in depth, but just as a reference, if you had a question of whether this really looked like rheumatoid arthritis or not. So as you can see in the little picture I have at the top, the joints that are kind of affected with those nodules or nodes, that's Heberden's nodes, are in the distal joints of the hand. And the characteristics of the joint issues are different. So you can review this at your leisure. So what are the diagnostic tests that are typically done? A SED rate, C-reactive protein, rheumatoid factor, anti-cyclic citrullonated peptide, or anti-CCP, or you'll see ACPA. Anti-nuclear antibody, complete blood count. There is a test called the Vectra DA, which I don't see, but it is available. It's an expensive investigational tool to make a diagnosis of rheumatoid arthritis. I haven't seen one yet. And then x-rays of the hands, wrist, feet to look for joint erosions. So we'll talk about these. So SED rate you're familiar with. So the higher the SED rate, the more likely inflammation. It's affecting not only the joints, but the body. So SED rate could be as low as 20 to 30, but you may see it 50 to 80 or even higher. So that kind of gives us a barometer of how much inflammation is going on. It's just the sedimentation of red cells, right? So that's easily done in the lab. And effective treatment with DMARDs or biologics can lower the SED rate, which is what you're looking for with treatment, right? You want to get improvement in inflammatory markers. This is an inflammatory disease. C-reactive protein is a pentagon-shaped protein. Put a picture of the pentagon there for you, which is involved in inflammation. It's an acute phase reactant, just like SED rate is. So it gives you an acute inflammatory response. And why was it called CRP? It was first identified in patients with a cell wall. The C polysaccharide reactive protein of the pneumococcus bacteria. So that's why it's CRP. And as you know, even for cardiac disease, highly sensitive CRP is helpful, even at very low levels. So the small HS CRP is used for that. So we have SED rate and C-reactive protein, right, as our inflammatory markers. The rheumatoid factor, it's positive in 70 to 80% of patients with rheumatoid arthritis, but that's kind of where the easy story ends because it's not specific for rheumatoid arthritis. And less than a third of patients with a positive rheumatoid factor will be found to have rheumatoid arthritis. It may be positive in other connective tissue diseases like SLE. And then a lot of healthy people or people over the age of 65 will have a positive rheumatoid factor even though they're completely healthy and don't have rheumatoid arthritis. So, it's helpful to make a diagnosis, but there's issues when the test is positive and you don't have all the other factors that you're looking for. A titer, the rheumatoid factor increases with the severity. So in this case, a higher titer would help you make a diagnosis of, or help you with the finding out the severity of rheumatoid arthritis. And the reason I mention that is we're going to compare that with something else in just a minute. So these are all the other conditions where you can have a positive rheumatoid factor. So there's a lot, right? I mean, it can be very confusing when you're trying to sort through and figure out if somebody has some arthritis and they may have one of these other diseases, or they're over 65 and completely healthy. It could be post-vaccination something, or post-transfusion. So there's a lot of reasons to have a positive rheumatoid factor. So that's not the only thing that's going to help us make a diagnosis, right? So there's another test which you probably see in APSs. Sometimes you have to kind of dig through the lab findings, and with APSs that we get, sometimes it's hard to find this particular test, but keep looking. If somebody has suspected rheumatoid arthritis, either it's called anti-cyclic citrullonated peptide, anti-CCP, or it's anti-citrullonated protein antibodies, ACPA. So if you see something that says citrullonated, you're probably talking about something that was done to see if there's rheumatoid arthritis, and it kind of is associated with inflammation or an inflammatory response. And it's present in 70 to 80% of rheumatoid arthritis patients. So it can be found in other rheumatic diseases, however. So the sensitivity is about equal to rheumatoid factor. So neither of them are great on the sensitivity. Well, they're kind of equal on the sensitivity side. On the specificity side, it's a little bit better than rheumatoid factor. However, remember I just said that as the titer increased in the rheumatoid factor, it kind of gave you an idea of severity. It's not quite as useful in that regard or in the progression of rheumatoid arthritis. So it's more about making the diagnosis. That's where it's helpful. So we had the inflammatory markers. Now we have rheumatoid factor and anti-CCP. So what happens though, sometimes, which may be in the initial phase of rheumatoid arthritis, up to 50% of people have the arthritis but don't have either rheumatoid factor or anti-CCP, especially early in the course of the disease. So you may have to keep retesting every 6 or 12 months if the joint findings appear to be rheumatoid arthritis, but they continue to be seronegative. You may want to keep testing to look for it. But once you've made the diagnosis of rheumatoid arthritis and they are positive, you don't need to keep rechecking a rheumatoid factor or anti-CCP. So once you've made the diagnosis, you don't have to keep repeating those. And seronegative, where if either of those tests are negative, they still have the typical symmetrical small joint activity. The severity may be less than the typical seropositive rheumatoid arthritis, but you probably don't want to delay using a DMARD to treat it so that it doesn't progress in terms of joint destruction. So if it looks like a duck, it sounds like a duck, it walks like a duck, it's probably a duck. So it's probably rheumatoid arthritis, even though the rheumatoid factor or anti-CCP may not be positive initially. Hematologic factors in rheumatoid arthritis, it's kind of the poster child for anemia of chronic disease or a normochromic, normocytic anemia. So, modestly low hematocrit and hemoglobin due to ineffective erythropoiesis. You could have a somewhat increased platelet count, so thrombocytosis. The white count could be mildly increased, or it could be decreased. If it's decreased, that there is a syndrome called Felty syndrome, which is rheumatoid arthritis with leukopenia. And part of the CBC, you may see the SED rate, which we talked about, would be likely increased, right? So inflammation is the risk factor we want to talk about today. So unabated inflammation is the bad actor in rheumatoid arthritis and other autoimmune diseases. So what we're kind of zeroing in on today is the inflammatory factors don't just prey on the joints, but they attack other vital body systems like the cardiovascular system. So that's kind of where we're going to focus today. So ratings for rheumatoid arthritis reflect the inherent mortality risk for the cardiovascular system and other targets of inflammation. So it's this inflammation that we see in rheumatoid arthritis affecting the joints. That's what we've always been concerned about. But what are the other targets that this inflammation is hitting? So that's what we're going to key in on today. And key treatments would be directed to decrease the inflammation, not just for the joints, but for the entire body, right? Including the cardiovascular system. So now we're going to talk about this inflammatory response that occurs in rheumatoid arthritis. And to get to that, we kind of have to talk about the ingredients that are necessary for this inflammatory response. So there's one word that always gives me a headache when I see it, and it's cytokines, because I never really understood what it was, and it always kind of was difficult for me to get my head around. But we're going to talk about cytokines today. So today I'm going to be Dr. Cytokine, and we're going to delve into what are cytokines and why are we interested in them. So normally, when we have an appropriate inflammatory response in our body, cytokines and cellular activation for infections or injury help us out as a natural body response, right? So if you're healthy and your body naturally manages the amount, the inflammatory response, that's good. So if you get injured or you have an infection, you want your body to respond with an inflammatory response. But what happens in diseases is you end up with an overproduction of these cytokines and more cellular response than you wanted. So that leads to inflammation and painful symptoms that cause problems. And the inflammation is not just limited to the offending infection or whatever would have been in a healthy response, but it's an unhealthy response. And it may not just be affecting joints, but affecting the heart, arteries, or other systems. So today I spared no expense, and these are the graphics which I did personally since I didn't have really a budget for the talk. So I drew this picture for you. The left side is normal, a normal joint, supposedly, with articular cartilage. And the right side is what happens in rheumatoid arthritis with synovitis or inflammation in the joint, with cartilage destruction. And then I've circled in red, what are the bad actors that are causing the problem? And it's the cytokines, and I called it a cytokine soup. The T and B cells, T and B lymphocytes, and macrophages. Okay, so those are causing the problem when we have an overactive inflammatory response, and particularly in rheumatoid arthritis, it's affecting the joints with cartilage and bone destruction. So what's a cytokine? So it's kind of a broad and loose category of peptides important in cell signaling and immunomodulation in good health, but what happens in problems like rheumatoid arthritis is they kind of they are overproduced and cause problems. So the word comes from Greek. I had to throw some Greek in, cyto for cell and kine for movement. So it kind of is a signal to cells to move. These cytokines are produced by cells like T and B lymphocytes, macrophages, mast cells, those kind of things. And the ones we're going to talk about are tumor necrosis factor, alpha, TNF, and some other difficult words to kind of wrap your head around, like interleukins, lymphokines, and interferon gamma. So in the little picture below, you see cells. So that could be T cells or B cells or macrophages or mast cells and all that sprinkled stuff that's all around there. We'll call those cytokines that are released. So those are problematic if they're produced in that too great of amount. So cytokines and the cytokine cascade. So what is this immune soup of all these ingredients? So I have some minestrone up here in the right upper corner. So cytokines affect the growth of all blood cells and other cells involved in immune and inflammatory responses. However, when the body overproduces any one or more of the ingredients in the soup, bad things can happen, right? You get bad soup. So it's like adding too much salt, too much pepper, something is in there that doesn't taste good. So it kind of messes up soup. Not all rheumatoid arthritis has the same amount of bad ingredients. So that's why different DMARDs may be tried, as you've noticed when you see a person that has an applicant that has rheumatoid arthritis, they may have been tried on multiple different drugs in order to try to get a handle on the inflammation and prevent joint problems. So it's kind of like here's a picture of my campus when I was at college. Every spring, it seemed like there was a protest. You know, some activists would start a protest on campus. It would kind of mushroom up. Um, some of the rebels would go rogue. There'd be an uprising and a toxic environment. The revolutionary group would cause would be a destructive movement that ensued to drive chronic problems. So it's kind of like when rheumatoid arthritis starts. You know, there's some activist cells cause a problem. So it disrupts the peace and tranquility in the joints, and other bystander organ systems can become collateral damage in the process. So you need anti-insurgent DMARDs or biologics to assist the body's defenses to put down the various rebellions, and peace can be restored. So when we would have an uprising on campus every spring, the National Guard of North Carolina would be called in, and that smoke you see is pepper gas. So it really wasn't spring without the smell of the flowers, the trees, and a little pepper gas. So I kind of miss the good old days. Anyway, ratings for the inflammatory response in the cardiovascular or other key systems. You know, people don't die of arthritis in their joints, right? They can have disability, but that's not really the cause of their death. It's really the downstream systemic inflammatory process that's affecting other organs like the heart, blood vessels, etc. So a higher level of inflammation would add higher mortality risk, and rheumatoid arthritis has about a 1.5-fold risk of atherosclerotic cardiovascular disease compared with the general population. So now we're going to talk about treatment in order to put down this inflammation or improve the general system when we do have an inflammatory process, as in rheumatoid arthritis. So we have the traditional DMARDs that I'm going to talk about. Have biologic treatments like anti-tumor necrosis factor drugs. We're going to talk about those. They're usually monoclonal antibodies, and we'll talk about what that means. And they usually the end of the chemical name is usually ending in MAB. So if you see something advertised on TV for rheumatoid arthritis or some other disease and it ends in MAB, it's probably a monoclonal antibody. I'm going to talk about alternative agents, and this is a mouthful. Selective co-stimulation modulators, and you say, well, that's a little too complex. Why did he even include that? And I'll show you why I included it. Other alternative agents include Janus kinase inhibitors or JAK inhibitors. And if you see those advertised on TV, they usually end in NIBS. So those are the NIBs. We have the MABs and the NIBs. So those are Janus kinase inhibitors. We'll talk about those. And then the new wave are called interleukin inhibitors. So we've got all these different ways of treating what we think is the same disease, but maybe it's kind of a different disease depending on what the particular cytokine cascade looks like, right? So that's why different drugs are tried on different people, or multiple drugs tried on one person. And then for short-term use, you may see steroids used. right? So the good old school disease-modifying anti-rheumatic drugs are methotrexate, hydroxychloroquine, Plaquenil, sulfasalazine, which is also used in inflammatory bowel disease, and the flutamide. Just some interesting feature about hydroxychloroquine that I'll mention here is that it actually was used first as to treat malaria, and because it has a quinine base, many hundreds of years ago, quinine was used to prevent malaria, so people drank tonic water or quinine water, but it had kind of a bitter taste, so it tasted a lot better if you drank it with gin. So that's where we got gin and tonic. So good old quinine water or tonic water was originally used for anti-malarial purposes, but it took on something more enjoyable as time went on. And we'll talk a little bit more about these DMARDs as we go. Methotrexate, which we see very commonly, right? It has immunosuppressive effects and anti-inflammatory activity in rheumatoid arthritis. It's also used in psoriasis, as you know. People that use it may take folate supplements because it does affect folate metabolism. Avoid it during pregnancy. And maybe a little known fact is that caffeine reduces the effect of methotrexate. So if you're having side effects when you use methotrexate, you could drink more caffeine to reduce the effect, or if the increased caffeine intake is causing treatment failure, you may need to either decrease the caffeine intake or take some other measure to help the methotrexate work better. And we're going to talk about biologic drugs too. So we see in a lot of foods it says non-GMO, verified. Well, this is the complete opposite of non-GMO. This is GMO. It's all genetically engineered proteins. And they're genetically engineered to zero in on specific parts of the inflammatory process. So hopefully, when used, they can prevent long-term disability from rheumatoid arthritis, and they're usually used in moderate to severe disease that doesn't respond to the traditional DMARDs that we just talked about, like methotrexate or Plaquenil. So therapies used to treat rheumatoid arthritis hopefully also prevent the inflammatory problems develop in the heart by suppressing inflammation. And many types of biologics have been developed since the pathway to rheumatoid arthritis may be multifactorial imbalance of those cytokines or cellular activation. So biologic DMARDs, sometimes it's written small p, DMARDs, are used in rheumatoid arthritis to treat the cytokine imbalance, and they're specifically going to target one of these things, like anti-tumor necrosis factor inhibitors, that T cell co-stimulator inhibitor that I mentioned, interleukin inhibitors, or Janus kinase inhibitors. Now you probably say, well, this seems pretty complex. Why is this bringing up all these medicines? I'm not really a pharmacologist, but this is where medicine is going in a lot of areas, are these monoclonal antibodies. So if you're really going to do critical thinking on a case, I think you really need to start dipping into what are the specific treatments and what do I need to know about these kinds of drugs in order to understand the case better, get a better feel for how they can help prevent progression of the disease, and hopefully help the applicant improve and do better so that we can rate better. So these medications help to rectify a specific inflammatory cellular response and toxic cytokine imbalance. And I did interview an AbbVie, that's a big drug company. It used to be part of Abbott Labs, but now it's a separate drug company. And I talked to a research executive who said that although companies are producing all these types of drugs, the interleukins are likely the new source of novel treatments in the future. So you're probably going to see more drugs that are directed against the interleukins as the cytokine that causes problems. Maybe the benefit will be better heading in that direction. So hopefully when someone has rheumatoid arthritis, the correct drug or the drug that has the best effect will be found. So this is probably a good slide to cut out, just stick up on your, I have it up on my wall so I can remember the names, because the names are so complex, it's hard to keep track, and they keep adding new drugs all the time. So the biologic DMARDs and the targeted synthetic DMARDs. So the first group are the tumor necrosis factor inhibitors. And if you'll notice, all but one have that MAB at the end of the drug's name. That means they're all monoclonal antibodies. There's one drug under the T cell co-stimulatory inhibitor. That's abatacept. There's a group called interleukin receptor inhibitors, and this is interleukin 6 receptor inhibitors. We'll just mention that there are interleukin 23 receptor inhibitors that are advertised on TV a lot. Those are used in psoriatic arthritis. You've probably heard of Skyrizi, Tremfya, Stelara. Those are against interleukin 23. So that's kind of like where the whole drug scene is heading, to interleukin type inhibitors. And then at the bottom, the group is called Janus kinase inhibitors, and you may have heard of Xeljanz or Rinvoq advertised on TV. That particular group are actually oral medications. So people prefer to have an oral drug if they can, help them with their rheumatoid arthritis. Unfortunately, they don't work quite as well as the drugs that are above that may be given sub-Q or IV. But there are advantages to having an oral drug that may help as well. So we'll talk about these anti-TNF biologics. So the drugs that are anti-tumor necrosis factor, what they do is they stop the create inflammation now message that TNF puts out when it's released. So it neutralizes the tumor necrosis factor. So in rheumatoid arthritis, TNF causes bone remodeling and mediates cardiac injury. So if you have a drug that negates the tumor necrosis factor, that's very helpful, right? And so these are engineered monoclonal antibodies, or the MABs, as I mentioned. And you've heard of Humira, Remicade, etc. And then there is one, etanercept, that's Enbrel, that kind of is a TNF receptor blocker. So it blocks the receptor rather than hooking on to the actual TNF that's floating around. So this is big business. I don't know if you know how big a business this is, but drug companies actually like the people that have chronic diseases like this because they have to keep taking the medications, right? So that's why the interest in research is so is going on in such a degree. So here's a picture of kind of what the drug companies are doing when they're making these new drugs. So right here I have a human immunoglobulin antibody to the left, and that's IgG. So you've heard of IgG. You see the levels in APSs, right? And an IgG kind of looks like a Y. So it has heavy chains and light chains, and it looks like a Y. And what it does is that it's binding site, it binds an antigen. So normally in our body, if we have an infection or some other injury or whatever, the IgG is circulated by the plasma cells and it goes and finds the antigen and binds it, like I have shown here, the little green triangle. So it binds at the binding site, it binds the antigen. So what the drug companies have done has taken the same model, and what they want to do is bind a specific cytokine. So what they have created are these monoclonal, or one clone of light chains and heavy chains to look just like an IgG that bind the tumor necrosis factor to remove it from the system so there's not as much inflammation. So it shuts off that create inflammation now. And so, again, my drawings, and you can see how similar the anti-tumor necrosis factor, in this case it's Humira, looks like an IgG. So whenever you see these Ys, like if you see an advertisement on TV and something has a Y that looks like that, they're probably talking about a monoclonal antibody. It's been genetically engineered to go after some particular factor like this. So hopefully that helps you understand like what the drug companies are actually creating. So how big a business is it? Just Humira is the world's #1 drug in sales, and just that drug alone for AbbVie generated $20.7 billion in 2021, which is almost as much as McDonald's sold in hamburgers and French fries in 2021. So that's a lot of revenue from one particular drug, right? It's big business. And just to give you an idea on the relative cost of things, I looked it up on Amazon, and methotrexate is a very reasonable $15 for 28 days supply, whereas a Humira set of 2 pens is $6,538. So you can see the differential in price. If somebody was able to be treated effectively with methotrexate, a much less expensive proposition, right? Whereas the Humira pens are pretty expensive, as are most all the biologics. So when you see these drugs advertised on TV, they don't even advertise Humira anymore because it's such a good seller as it is. They don't need to advertise. But whenever you see a drug advertised for psoriatic arthritis or atopic dermatitis or inflammatory bowel disease, I mean, those are very expensive medications. Now, I told you this is kind of like a one drug in this particular category, but the reason I bring it up is if I don't mention it and you see it, you'll probably be scratching your head just like I was. And what is this particular drug? So that's why I threw it in here. You can look back maybe someday when you have a question about it, but it's called a selective co-stimulation modulator. So I didn't even have any idea what that meant, but it has the word BAT in it. So I picked out a couple of bats, and what it is, it's like if 2 bats were blocking a secondary verification when you sign on to a website. So say you have to sign on to your VPN and you have a little device that gives you a number to plug in, right? This blocks that secondary verification. So the abatacept or Orencia blocks that secondary verification. So if you remember the BATs and the blocking the secondary verification, you'll remember what this particular drug does. And I've seen it. And so what it does is when the overactive T lymphocyte, like at the bottom, is trying to hook up with the joint cell and start a destructive process, the 2 BATs actually block secondary verification. So it inactivates the ability of the overactive T lymphocyte to affect the joint cell. So you stop the progression of inflammation. So that's a co-stimulation modulator. I just want to mention the Janus kinase inhibitors. They were initially called just another kinase. JAK 1 and 2, but ultimately called Janus kinase because two-faced Roman god Janus is indicative of the JAK's near identical mirror image and sites of action. So it's another group of drugs which are the NIBs that I mentioned, and it's Xeljanz or Rinvoq, and these are oral, and but not quite as effective as some of the other drugs, but still an oral drug that helps is still an advancement. So who should not take biologics? So if someone has a dormant chronic disease like latent or active TB, that would be a bad thing to start biologics. Or if they have hepatitis B on a chronic basis or hepatitis C, it could cause any of those to flare. So those would be bad things to have happen if you start a biologic, right? So as an underwriter, one of the things you may want to do is keep a close eye on whether the applicant who may be on a biologic, maybe they were just started on it, make sure that they've been screened for any of these dormant chronic diseases so they're not present, since the outcome could be disastrous if they haven't been checked. So that we'll talk about keeping an eye on that. Also, if someone has multiple sclerosis or like early signs of congestive heart failure or had heart failure and now they're a little better, these also might be worrisome to start. So you wouldn't want to use biologics. And people at risk for cancer or undergoing cancer treatment or pregnant women, these are all people that may not be the best thing to start. People need to be monitored with lab tests if they're started on biologics. And if you're going to have surgery, your doctor would probably stop the biologic before surgery and let your wounds heal first. So, it's not all happy news with biologics. You have to be careful when you use them. So, with TB, we always want to know, is there a latent infection with tuberculosis or active TB possible? So that's why we do skin tests to check for latent disease. If someone had a positive skin test or a positive IRGA test, that's a blood test for TB, but has a negative sputum culture and a negative chest x-ray, they may have a latent infection with tuberculosis. Active disease, positive skin test or positive blood test for TB, but they would have a positive sputum culture and positive chest x-ray. So in either case, people are going to need to be treated for their TB, whether it's latent or active, before they can take a biologic. So latent infection would be like a positive skin test like you see on the left, and you just measure the indurated area, not the red area. And on the right, a chest x-ray that shows active disease with TB infiltrate or TB cavity. Obviously, you would need to treat that person for a long time before they would be able to take any biologic treatment. So to give you kind of an example of latent, dormant infection, you can see the picture on the left versus active disease, or the picture on the right. If you all have teenagers at home, you know what I'm talking about. So what's this TB blood test anyway? And actually the CDC is kind of recommending people use this instead of the skin test, because people don't have to get the skin test read, and it's difficult doing the skin test correctly. So there's a lot of reasons why people are moving to these IGRA tests, or interferon gamma release assays, which is a big term for the blood test for TB. And the gold standard right now has actually got gold in its name. It's called the QuantiFERON TB Gold Plus blood test, or QFT Plus. That's the 4th generation of this test. And what it means, if you have a positive test, means the person's been infected with TB bacteria, but they may have either latent or active TB disease. So you need to check and see, chest x-ray positive, whatever. If the blood test, the IgRA is negative, they do not react to the test, then latent TB infection or TB disease is not likely. So that's an important screening test before somebody gets put on a biologic, right? So I'm going to go through this again. If you're going to do some critical thinking, it's probably a good idea to know what's behind these tests that you're going to be using to make these important decisions, right? So this is the QuantiFERON TB Gold Plus test, 4th generation. So there's 4 tubes now. They added the yellow tube to make it the 4th generation. So there's a lot of reasons why this test could be done incorrectly, including you're supposed to keep the tubes at room temperature and shake the tubes after the blood is drawn. You're not supposed to centrifuge or refrigerate the tube. So you can already see there's reasons that could cause the test to be inaccurate, right? You have to perform the test within 14 to 16 hours of the blood draw. It should be at the lab by 14 hours. It should be done within 2 hours of being at the lab if that's the case. And any other mycobacterial disease could give a false positive. So if you had a mycobacteria marinum skin disease, that could, cause a false positive. So 4 tubes. And you'll notice I circled in red. There's a tube called nil. There's a tube called TB1. There's a tube called TB2. And there's a tube called mitogen. So we're going to dive into the weeds. So hang in there with me. I know this is kind of tough, but it's worth knowing at least once exactly what's going on behind the curtain here, okay? So tube 1, that's the green top, has CD4 cell antigens that recognize old or new TB antigens. Tube TB2, that's the 4th generation, the new tube they added, has CD8 cell antigens in addition to CD4. It reflects activity of new or active infections. So there's a difference between TB1 and TB2. The greater the difference between those 2 tubes, the more likely an active or new infection is present. And the control tubes are standardizers so that you know whether the test is been performed correctly. So the nil tube should register near 0 when the testing is performed, and the mitogen test should be the positive standard. So those must be correct in order for the test to work out right. So seems like a lot of details I'm going into here, and you're probably scratching your head why. But anyway, the way the test is actually done is you subtract the nil result from the TB1 and the TB2 result. If it's greater than a 0.35, it's positive. So you may not remember this as you go through the cases that you see in the future, but you can refer back to this and get a sense of what I was talking about. So in this case, you may see it reported as this. So on the left, you'll see the TB1 tube, the TB2 tube, the nil value, and the mitogen value. At the top, it says QuantiFERON TB Gold Plus performed positive. The reference range is negative. So this was recorded as positive, and the reason is you take the TB1 value and subtract the nil value. So you have TB1 was 0.59, you subtract 0.08, you get 0.51. That's greater than 0.35, so it's positive. For the TB2, it's 1.09. You subtract the nil value, which was 0.08, you get 1.01. So you have 2 positives here. So the test is positive. And you can see the nil value is very low, like it should be, as a nil value, so it's close to 0. And the mitogen value was greater than 10. So that's the standard positive. So this is appropriately done, and it is a positive test. Now, when you see an APS, it may just say positive, and it may not have all these other factors. But if they're there, then you can now make your judgment as to whether it was done correctly, okay? So we have a case study, a 42-year-old person with rheumatoid arthritis. Methotrexate has not been effective, so a biologic treatment is planned. So quantiferon is ordered. And just like we saw on the last slide, the test is reported as positive. So what's going to happen here? And I use the same numbers that we just went through. So when you subtract out the nil value from the TB1 tube and TB2 tube, both are greater than 0.35. The mitogen value is greater than 10. The nil value is low, almost 0. So this person would need to be treated. Well, first they need to find out whether it's active or latent disease, TB, right, before a biologic could be used. So they need to go on some sort of treatment program, whether it's for latent or active disease. And then the biologic could be considered in the future. So when you're doing baseline screening in rheumatoid arthritis for latent TB or active TB, it needs to be done before biologic therapy. If you have a positive quantiferon test and they had a latent, you found out that this was latent TB disease, they need at least 1 month of treatment before the biologic could be started. You can check out the CDC website for what the short and long course treatments are for latent disease. And then they probably need to be monitored for that on a regular basis. This is the same case, but I just want to show you, if you look at what I've circled in red, this test was supposedly being reported as negative, but look at the nil value circled in red. The nil value here is greater than 10, and the mitogen value, or the standard, is 0.08. So it's like they've been reversed. So if you saw all these numbers, you would be suspicious that this test was not done correctly. So that's why I've gone into this great detail, probably more than you wanted to hear. So you may actually pick up on a test that was actually done incorrectly. And that may affect the way you want to rate the case. The other things that we look for before we treat with biologics are hepatitis B and C reactivation. We certainly don't want to activate those two diseases because you can actually have hepatic decompensation, fulminant hepatic failure, and death if you started a biologic and the person had either hepatitis B or hepatitis C. So you have to be cautious, and as underwriters, we don't want to be taking cases where they have either of those diseases and then are started on a biologic, right? So we had talked about anti-TNF therapy, and actually in HIV positive applicants, which we're reviewing those cases now, you can use safely an anti-TNF drug. They can be safely administered if the CD4 count is adequate. However, you would not want to use them in CHF, congestive heart failure, or multiple sclerosis cases. The drug would be contraindicated in those kind of cases. I just want to mention interstitial lung disease, which can occur with rheumatoid arthritis. Couldn't, miss mentioning something about pulmonary, right? So you can have all kinds of scarring, even some things that look like nodules in the lung associated with rheumatoid arthritis. And things can get pretty grim, requiring immunosuppressants, supplemental oxygen, or even lung transplants in really severe cases. So the lungs can also be collateral damage, as is the heart, rheumatoid arthritis. So I want to mention this case for one particular reason, and we're getting close to time. If you notice, the SED rate is only 7. That's about the 4th bullet down. When we consider this in terms of inflammatory disease, I would consider this a super low risk because the SED rate is so low. So when you're rating cases and the SED rate or CRP is very low, even before therapy, your risk of the inflammation, which can affect the cardiac and other system, is probably low. So things to consider when you're doing your workout. You can also think of, on your own, creating like a mini spreadsheet. When you do a case, has there been TB screening, hepatitis B and C screening? And then for the visits that you can find, are the SED rate, CRP, and what meds have been used on the dates in order to keep track of what the progress is on the particular case. And again, when you have a really low SED rate, even though it's only ranked as 1 point, probably the inflammation factor is low. So since we're talking about this as an inflammatory disease, hopefully things are not as grim as they might be if the case had a really super high SED rate. So our takeaways are, we're talking about this as an inflammatory disease. Remember to screen for, or hopefully they've been screened for hepatitis B, C, and tuberculosis. And I'm going to end with this slide. Critical thinking. This is Yogi Berra, who played for the New York Yankees, on the right. And he used to give out phrases that were kind of memorable. I kind of paraphrase this one, and 90% of underwriting is 50% mental. And that's when I was a bat boy for the Cardinals a long time ago. So I've completed the session for today.